I'll take a photo. I can share that.
Okay, guys. All right, everyone. That one? Okay. Hi, everyone. We might just make a start. I know you've had quite a long day, and so you're probably all anxious to leave. And so we'll try and get through this as quickly as possible. If you've got questions at any time, feel free to just throw your hand in the air. So today I'll just be going through anatomy, physiology, microbiology, and pharmacology, and some of the clinical conditions at the end. Going straight in with the anatomy, so you've got the thoracic cage, you've got your ribs. Yes. Sorry, I've been told I need to start now.
Sorry guys, we need to finish a bit early because AMSA wants everyone like as many people as possible to go to their event. So group 8 might miss out on a bit of the anatomy at the start.
Anatomy at the start, it's all on the slides, it should be okay. So true ribs, ribs 1 to 7, they articulate with the sternum through their own costal cartilage. Then false ribs 8, 9, 10, and then floating ribs 11 and 12 don't articulate at all. You've then got the split between typical and atypical. So typical ribs 3 to 9, they articulate with the numerically corresponding vertebra and the one above. And then atypical ribs 1, 2, and then 10 to 12. So 1 articulates with only one rib, 2 has the tuberosity serratus anterior, 10 to 12 also only have one facet for articulation with the numerically corresponding vertebrae. Ribs 2 to 6 increase the anterior-posterior diameter of the thorax in respiration, and 7 to 10 increase the transverse diameter. The rest of the bones, you've got your thoracic vertebrae, so heart-shaped body, long spinous process, and then just the sternum, so manubrium, body, and xiphoid process. Apertures, you've got the superior thoracic aperture, which is also the thoracic inlet. Gets a bit confusing because it's where you have thoracic outlet syndrome, but it's technically the inlet. And then the inferior thoracic aperture, and they just give passage to the neurovasculature and viscera moving up and down. Going into the muscles, and to start with the diaphragm. So it's your trinth muscle of respiration. During expiration, the right dome reaches the 5th rib, the left the 5th intercostal space. So the right's a little higher because of the placement of the liver. Its innervation is motor from the right and left phrenic nerves, so B3, 4, and 5. Paralysis of one of the phrenic nerves means that that half of the diaphragm won't go down during expiration. This means that it actually paradoxically rises during inspiration because of the pressure from the abdominal viscera. And so that's just this diagram down here. With the paralyzed diaphragm, that side rises on inspiration. The sensory innervation of the diaphragm is the phrenic nerve centrally, and then the intercostal and subcostal nerves around the periphery. Sorry guys, this is an early start. In terms of apertures, you've got the IVC at T8, the esophagus at T10, and the aorta at T12. For the rest of the muscles, you've got moving from external to internal, the external intercostals. Fibers run infero-anteriorly. They're active during inspiration, and they're placed anteriorly from about the mid-clavicular line towards the sternum by a membrane. The internal intercostals are kind of the opposite, so the fibers run at a 90-degree angle infero-posteriorly. They're active during forced expiration, and they're replaced posteriorly by membrane from about midway through the scapula to the vertebrae. The innermost intercostals are essentially the same as the internal intercostals, but they're separated by the neurovascular bundle between each rib. Subcostal muscles and transverse thoraces aren't as important, but they're also present. Between the internal and innermost intercostals, as I said, is the neurovascular bundle. So from superior to inferior, you've got vein, artery, nerve, VAN, and they run at the inferior border of the rib. For that reason, if you're giving an intercostal nerve block, you don't want to directly hit the nerve, so you should give it at the superior margin of the rib. In terms of the pleura, the cavities are lined by two layers of pleura, so parietal over the outside and visceral over the lung surfaces themselves. They're separated by a thin layer of serous fluid, and it serves to decrease surface tension so they can slide over each other and reduce friction, while it also holds the two of them together and allows the lungs to expand while the thoracic cage expands. The visceral pleura is continuous with the parietal at the pulmonary ligament. So the parietal pleura has three parts, and that has somatic innervation. So it's sensitive to pain, it's a sharp pain, and it'll be more localized. Sorry, guys. Three different areas have different pain sources. So the costal areas are supplied, the costal surfaces are supplied by the intercostal nerves, mediastinal by the phrenic nerves, same as the diaphragm, and diaphragmatic by the intercostal nerves peripherally and phrenic nerves centrally. Because the phrenic nerve innervates the pericardium as well as the mediastinal pleura, the pain from mediastinal parietal pleura can mimic pericardial pain. Both of them can also radiate to the shoulder, which is where the C3, 4, 5 nerve roots of the phrenic nerve are located. The visceral pleura, by contrast, has only the visceral innervation, so it's sensitive to stretch, not well localized pain. In terms of where they all reach, the pleura reach the 12th rib posteriorly, and from there you just count by twos. So pleura is 12th posteriorly, 10th laterally, and 8th anteriorly, while the lungs are two above. So 10th posteriorly, 8th laterally, and 6th anteriorly. I've just made a note there also because I think it's in your anatomy book that esophageal pain, which has nerve roots T4 to 6, can mimic cardiac pain, which shares similar nerve roots from T1 to 5. The pleura is vulnerable to penetrating injury in three key places. So at the apex of the lung, where you can get in between the ribs, and that's particularly vulnerable in infants or young children because the lungs extend further superiorly. Also at the inferior to the costal margin, so at the costodepisternal angle, and then posterior to the 12th rib. If you do get a penetrating injury into the pleural cavity and you get a pneumothorax where air enters the cavity, the lung is no longer going to be held to the thoracic wall by that surface tension we were talking about earlier, which means that it will collapse. The trachea in that case will deviate towards the affected side because it creates essentially a vacuum on that side. That contrasts with a tension pneumothorax where air can enter but not exit the pleural space. So this is when you get a hole in the lung with tissue acting essentially as a valve. Air can exit into the pleural space but then can't leave. This starts putting compression on all of your mediastinal viscera, so your heart, your great vessels, and will cause respiratory arrest. It's a medical emergency, and for emergency treatment, you put in a chest tube in the 5th or 6th intercostal space at the mid-axillary line. The needle into the 2nd intercostal space in the mid-clavicular line. Then for more permanent treatment, you put in the chest tube. Am I going at an okay pace right now? Okay. So into the lungs themselves. Right lung, 3 lobes, 2 fissures, and around 10 bronchopulmonary segments, which are surgically resectable. So each is supplied by its own tertiary artery, bronchus, and vein. Left lung has 2 lobes, 1 fissure, and contains the lingula, which just curves over the heart and has 8 bronchopulmonary segments. The lungs are attached to the mediastinum by the lung roots, and that's the bronchi and vessels. The right lung is larger and heavier than the left, but it's also shorter and wider due to the placement of the liver. What else is important here? In the right lung, at the right hilum, the right main bronchus is superior, while the pulmonary arteries are more anterior. So that's what this picture is showing you here. Whereas on the left side, the pulmonary artery is more superior. For the nerves, vessels, and lymphatics, innervation of the lungs is via the pulmonary plexus. And so that's going to be carrying both sympathetic and parasympathetic fibers. Parasympathetic stimulation will do bronchoconstriction, whereas sympathetic will do bronchodilation and make it easier to breathe. The left and right pulmonary arteries arise from the pulmonary trunk at the level of the sternal angle. They then divide into the lobar arteries, which arise prior to the entry to the hilum. The arteries and the bronchi are paired in the lungs, so they'll run together and branch simultaneously. By contrast, the pulmonary veins arise independently and won't travel along with that bundle. The bronchial arteries supply oxygen and nutrition to the lungs and the visceral pleura, so the parenchyma, whereas the pulmonary arteries are the ones that are carrying the deoxygenated blood to be oxygenated at the lungs. In terms of lymphatic drainage, and also on that, the bronchial veins will then drain into the pulmonary veins before they reach the systemic circulation. So a small amount of deoxygenated blood will be added back into that freshly oxygenated blood before it enters the systemic circulation. In terms of lymphatic drainage, the right lung and the left inferior lobe both drain to the right lymphatic duct. The rest of the left lobe drains to the thoracic duct. Key nerves of the thorax are the vagus and phrenic nerves. So the vagus nerves pass posterior to the lung roots, the phrenic nerves pass anterior. Your vagus nerves are carrying parasympathetic innervation, and they give off two key branches that you're concerned about in the thorax, which are the recurrent laryngeal nerves. The right recurrent laryngeal nerve loops under the right subclavian, while the left loops under the arch of the aorta. It's particularly key because it can be damaged in surgeries, aneurysms of the aorta. If that occurs unilaterally, so with damage to the left side, you'll get a hoarse voice. If you manage to damage both recurrent laryngeal nerves, you'll have difficulty breathing. In terms of the vessels, it's pretty straightforward, no really good way of remembering it. Just in terms of the venous drainage, because it does occasionally come up. So the posterior intercostal veins are easy, they just drain straight into the azygous vein on the right side. On the left side, vein spaces 1 to 4 drain to the left superior intercostal vein, 5 to 8 to the accessory hemozygous, and 9 to 11 to the hemozygous veins. A little bit of histology just quickly. So the trachea is lined by pseudostratified ciliated columnar epithelium. It contains the C-shaped rings of hyaline cartilage and then has space at the back where the esophagus sits. Bronchi are lined by the same kind of epithelium, but the change here is they've got plates of cartilage and an increasing percentage of smooth muscle as you move more distally. Bronchioles then have no cartilage at all and contain smooth submucous glands or goblet cells, and they've got more smooth muscle again. At this point, the simple ciliated columnar epithelium is transitioning to simple cuboidal, and then the terminal bronchiole is where the first alveoli occurs. The right bronchi is shorter, wider, and more vertical than the left, which means foreign bodies are more likely to enter the right lung. They're more likely to then lodge in the apical segment of the lower lobe in a supine patient, or the posterior segment of the right lower lobe if the patient's upright. So these are just some more histology. So bronchus and here, and then a bronchiole with its alveoli. So anywhere you've got the plates of hyaline cartilage, which is here, and then in the blue, you know it's a bronchus at least. To the alveoli themselves, so location of gas exchange, 6 layers that air has to cross to get into the red cell itself. In the alveoli, we've got 2 key types of cells. So type 1, they cover 90% of the surface area, and they're the ones that form the air-blood barrier and that air will cross. Type 2 secretes surfactant. The last key thing, I think, for the anatomy is the transthoracic plane. So it's at the T4-5 vertebral level, second costal cartilage, and it's a key landmark in the neck. So at this location, you've got the recurrent laryngeal nerve looping under the aorta on the left, the azygous vein arching into the superior vena cava, the bottom of the arch of the aorta, the bifurcation of the trachea, and the crossing of the thoracic duct from the right side inferiorly to the left side superiorly. Do we want to do questions now, or would you prefer to do those in your own time later? Anyone have a preference? All right. Now? Okay. Is anyone going to shout out the answer, or do you want to pick people? So the arrangement of the right lung hilum.
Just pick someone. Why not?
All right. Starting from the front down here. Maybe go in a group of 3 if one of you can answer it. Anyone? Sorry, I went over this really quickly.
Hey.
Close. All right. So yeah, right lung hilum, the bronchus is superior, the arteries are anterior. Where should a chest tube be put in? So this is your long-term. Yeah, perfect. At what level would this structure pass through the diaphragm? Yeah, I heard it down here. So that's the aorta, and so it's going to pass through. All right, and one last one. If you damage this structure, what condition will it mimic the pain of? Yeah, perfect. So that's the esophagus. Esophageal pain can mimic cardiac pain. Oh, sorry, one more. So characteristic of a bronchus. Okay, yeah. So plates of hyaline cartilage, no rings. So you've got the trachea over here, alveoli, and intestine. All right, moving into the physiology now. So the respiratory tract, a few different goals. It's divided into the upper and the lower respiratory system. The lower respiratory system can then be divided further into the conducting and the respiratory airways. Respiratory are where the gas exchange itself is occurring. And then within the alveoli, you've got those 3 different types of cells. At rest, the lungs have elasticity, so they want to collapse inwards, but the chest wall, because of the structure of the bones and the muscles, wants to expand outwards. This means that the pressure in the intrapleural space is negative, and the pleural fluid creates a surface tension that holds those 2 surfaces together. It means it's easy for them to slide over one another, reducing friction, but very difficult to pull them apart. Equilibrium, which you reach at the end of a normal expiration, occurs when the elastic recoil of the lungs and the chest wall are the same, so there's no movement. Muscles move the thorax from this position during inspiration, so primarily the diaphragm, and that's active, whereas return to it during expiration is normally passive, except for forced expiration. Transpulmonary pressure is the pressure across the lung wall, and it's calculated from the pressure inside the lung minus the pressure in the pleural space. This is probably the more important sort of table to wrap your head around for physiology. So this is just what everything's doing during inspiration and expiration. So if we begin in equilibrium, the transpulmonary pressure equals the elastic recoil of the lung. Nothing's going anywhere, there's no movement. In inspiration, the diaphragm will then contract and flatten, and the external intercostals contract. This increases the volume of the thorax. The intrathoracic volume increases, and as a result, the pressure there decreases. This means that the transpulmonary pressure exceeds the elastic recoil of the lung, and this just means the lungs expand. This causes the alveolar volume to increase. Alveolar pressure will drop below atmospheric pressure, and air will follow that pressure gradient to enter the alveoli. The reverse then happens during expiration. Does that make sense? It's probably one of the more important tables. Yep. Yeah?
That lung expansion, the transpulmonary pressure up to plastic. But with the strengthening of the lung, increase in size, the diaphragm that also size as well.
So it's attached to the visceral pleura, but not the parietal pleura. And so it relies on the negative interpleural pressure holding those 2 then surfaces then together, but has no direct attachment to the diaphragm itself.
Yes,
It's only, it just changes the pressure, yeah. This is then just a different kind of diagram. So volume, pressure, and flow. If you know what's happening with one of them during the respiratory cycle, you'll be able to work out what's happening with the rest. Volume increases in inspiration, decreases in expiration, and pressure will be equal between the alveoli and the atmosphere at the end of inspiration and the end of expiration. So anytime there's no air movement, you know that pressure is equal. Flow just follows the alveolar pressure. The other concepts of interest are compliance. So this is really just how easy it is to change the volume of the lung, and so that's determined by connective tissue and surfactant. Surfactant will decrease surface tension, and that results in an increase in compliance, and surfactant also serves to stabilise alveoli. Because they stabilise alveoli, the smaller alveoli, which are more prone to collapse, will have more surfactant to help keep them open. The other concept is resistance. You've encountered it before, so just know that radius is to the power of 4. It's the most important factor in determining resistance. Just briefly on surfactant, so it will decrease surface tension, increase compliance. Hysteresis is a concept you've probably just brushed over. It's not particularly important. I wouldn't worry too much if you don't get it. The basic kind of thing is that during inspiration, the surfactant molecules are stacked, which means that they're not very good at helping the lung expand. They're being pulled further apart, which is what they already want to do. So the surfactant molecules want to repel. During inspiration, they're being pulled apart, so they're not going to be particularly effective at helping the lung expand. Whereas during expiration, they're being brought closer together while they're already repelling each other. This means that they're helping to hold the lung open a bit more, and this gives the pressure a higher volume at a lower pressure during expiration when compared with inspiration. Within the lung, you've got ventilation and perfusion. So ventilation, the air movement, and perfusion, the blood circulation. Perfusion, the pulmonary circulation has a pressure of about 25/8, so that's compared to 120/80 in systemic circulation. And also different to the systemic circulation, you have hypoxic vasoconstriction occurring. So in the systemic circulation, if an area has low oxygen to it, you'll have vasodilation to try and get more oxygen. Opposites occurring in the lungs. If there's an area that isn't getting any oxygen, there'll be vasoconstriction, so less blood goes to that area, and more blood goes to the areas that are getting oxygen to then supply the systemic circulation. In the upright lung, ventilation is higher at the base of the lung and lower at the apex of the lung. This is because of the weight of the lung hangs down, and this pulls the alveoli at the apex of the lung wider open even at rest. This means that when you breathe in, they don't expand as far in terms of the change in their volume, which means you get less ventilation to the top of the lung as opposed to the bottom. However, because of the effects of gravity, perfusion, which is also higher at the base of the lung, has a bigger difference to it. So ventilation is lower at the apex, higher at the base. Perfusion is also lower at the apex, higher at the base, but there's a bigger difference. This means that the VQ ratio, so ventilation-perfusion ratio, will be greater at the top of the lung than the bottom of the lung. In terms of gas exchange, you have anatomical dead space, so no respiratory capacity, but it's normal, so that's like your trachea. And you've also got physiological dead space, which is where there should be gas exchange occurring, but there isn't in this particular instance because of pathology. So, for example, with pulmonary embolism or emphysema. The rest of the figures here aren't particularly important. The only other thing to note is that gas exchange is usually completed in about the first third of the capillary. When it comes to gas diffusion, anything that decreases the area available or impairs the gas transport, so anything like pulmonary edema or fibrosis or emphysema, will impair gas diffusion. And the rate of gas diffusion can be affected by partial pressure differences for the different gases, surface area available, the thickness of the wall that the air has to cross, and the diffusion coefficient of the gas. So for example, carbon dioxide is much more soluble than water. It'll diffuse at approximately 20 times the rate through tissues as oxygen. Oxygen is then transported primarily down to hemoglobin. It has a very low solubility, so only about 1.5% will be transported dissolved. The rest will be bound. This contrasts to carbon dioxide, which is split three ways. So 5 to 10% will be dissolved in the plasma, 20 to 30% will be present as carbon monohemoglobin, and then the majority will be present as bicarbonate. So carbon dioxide enters red blood cells, it gets converted into bicarbonate and will then be transported, dissolved in the blood in this fashion. And this is also because that's a base, how you can get respiratory compensation in acidosis. In terms of gas exchange and transport, the ability of oxygen to bind to hemoglobin will be affected by temperature, carbon dioxide, hydrogen ion concentration, and also the presence of other gases such as carbon monoxide. So if you get an increased temperature, for example, in tissues that are really active, then you shift the curve to the right and oxygen will unload. If you get a decreased temperature, decreased hydrogen ion concentration, this is more like what you're getting in the lungs. The curve shifts to the left and more oxygen will load onto hemoglobin. Because carbon monoxide has around 200 times the affinity of oxygen for hemoglobin, it shifts the curve to the left, which decreases unloading in tissues. And this is why if you get carbon monoxide poisoning, it will kill you. It doesn't stop your blood from being oxygenated, but it prevents the unloading of that oxygen. And so that's why you won't even notice, but you'll die quite rapidly. And so that's known as the Bohr effect. The similar concept for carbon dioxide is the Haldane effect. The other is in the alveoli themselves, so still for oxygen is the Haldane effect. I'm confusing myself here. It's for carbon dioxide. Binding of oxygen to hemoglobin reduces affinity for carbon dioxide, which is how carbon dioxide is unloaded in the lungs themselves. The control of respiration, it occurs in the central pattern generator, which is the medulla and the pons, and then there's communication to higher brain centres. That then sends out the signals, which is motor via the phrenic nerve and the spinal segmental nerves. It has two key tasks. So the first is just generating an automatic breathing rhythm so you don't have to think about it on a day-to-day basis. And then the other component of that will then be modulating it to change the body's needs. So when you start exercising, you start breathing more. The central chemoreceptors are located inside the blood-brain barrier, so they're the medullary chemoreceptors, and they're sensitive to the hydrogen ion concentration, which means they indirectly sense carbon dioxide levels. The peripheral chemoreceptors, so they're more of the carotid body, will sense oxygen, hydrogen ion concentration, and carbon dioxide concentration. Because oxygen doesn't change linearly, your oxygen saturation doesn't change linearly with your oxygen availability, so it's the sigmoidal curve we were looking at before. It's not a very useful thing to measure on a day-to-day basis to know how much oxygen you have. Instead, we use carbon dioxide, which is then because there's a linear change with amount of carbon dioxide. And so carbon dioxide is the main factor that's used to control respiration under normal circumstances. The only difficulty with that is over time, the body will equilibrate to a higher or lower carbon dioxide concentration, which means that your sensitivity to carbon dioxide is shortened. In the short term, it's going to have a very potent effect and it's going to be what's regulating ventilation. But in the longer term, it's going to have quite a weak effect, and then your chemoreceptors will lose sensitivity to carbon dioxide and gain it to oxygen. When you're looking at testing people clinically, spirometry is probably your key lung function test. It can't measure residual volume, functional residual capacity, or total lung capacity, but it can measure the other key volumes. In a normal person, FEV1, which is how much air you can breathe out in the first second of expiration, divided by functional vital capacity, so all the air you're exhaling, is about 0.8. If it drops much below that, then you're looking at an obstructive picture, which is, for example, asthma, COPD. The way you differentiate between those then is that in asthma, there'll be improvement on administration of a bronchodilator. So your lung function will improve, your FEV1 over FVC will improve. In COPD, there'll be no change. In restrictive conditions, the FEV1 is reduced, but because your vital capacity is also reduced, there's something physically stopping the lungs from expanding as much. The ratio usually is normal. Some of the other tests you can use include peak flow, so that you just need to take 3 different readings, and the reading that you take as the actual reading is the highest of the 3, not the average. And then we have a couple of different techniques for measuring those volumes that you couldn't measure through spirometry. So, for example, your residual volume. Not as important, but they're up there if you're interested. Okay, so moving into some questions now. Which of these is correct? Anyone? Do I pick someone? Okay, I think I heard it then. So it's D. So the pulmonary veins are what's carrying blood back to the heart. They've got a lower oxygen saturation than the blood in the pulmonary capillaries because the blood from the bronchial veins has been added to them. Which of the following is going to cause a right shift in the dissociation curve? So a right shift is going to increase unloading. Yeah, so it's decreased pH. So that's what you find in tissue. So increased hydrogen ion concentration, decreased pH. This one might be a bit tricky to do quickly. So that's your spirometry volumes, are probably worth knowing. All right. I'm sorry to be rushing through this so quickly, but I've been told that you have something else to get to at 6, so we'll just keep moving, if that's all right. All right. So to begin with, infections of the respiratory tract. These are probably fairly low yield. Just a couple of sort of key things. So, for example, acute sinusitis will usually clear on its own, but it's usually bacterial, so you can give an antibiotic. That contrasts with something like rhinitis, which is usually viral, only symptomatic therapy. Otitis externa, it's usually related to water in the ears, and the key causative organisms are here. Pseudomonas aeruginosa is also going to cause the necrotizing form, which will occur in the elderly or immunocompromised. Pharyngitis and tonsillitis is usually viral. If it's bacterial, it can be distinguished on clinical examination to some degree. You're more likely to have a fever, you're more likely to have tender lymph nodes, and you're more likely to have tonsillar swelling with an exudate, so a really red and inflamed throat. In that case, you'll treat with narrow spectrum penicillins because of the risk of rheumatic fever if you don't treat. Infectious mononucleosis, Epstein-Barr virus, oncogenic, probably about what you need to know for that. Crew will present with a biphasic stridor. It's the brassy barking cough, and it's common in quite young children. Pertussis is your inspiratory route, post-tussive vomiting and paroxysms of coughing. They're sort of the key words there. Here, diphtheria, gram-positive, barking cough, false membrane. They're the kind of words that usually get thrown out. Acute bronchiolitis is only in sort of children and neonates, so about 1 month to 1 year, and it's usually respiratory syncytial virus. Pneumonia consolidation will appear on chest x-ray at some point in the presentation, and that's sort of the cardinal sign, and it's most commonly Streptococcus pneumoniae. Empyema will usually require drainage and might complicate another infection such as pneumonia. Tuberculosis is uncommon in Australia, but usually presents with cough, weight loss, and fevers. And this is your treatment over here. So multi-drug resistance is increasing, so you treat with multiple different combination therapies. Cystic fibrosis is your autosomal recessive condition, heel prick diagnosis, and it's caused by the abnormal chloride channels. Infections with bugs that normally don't bother people, such as Pseudomonas and fungi, are more common. Influenza, orthomyxovirus, H&N proteins. Influenza A will undergo antigenic shift, which is the one you worry about. It's the one that causes epidemics, whereas B and C will only undergo shift. Just to spend a bit more time on asthma and COPD. So asthma is an inflammatory condition, and it's characterized by recurrent episodes of wheeze, cough, chest tightness, and breathlessness. There is airway inflammation and airway remodeling, which results in long-term changes to the airway structure. So you've got submucosal mucus gland hypertrophy, so there'll be more mucus being produced in future, damage to the epithelial cells, thickening of the basement membrane, and smooth muscle thickening. And so all of that is going to make future exacerbations of the asthma worse. Airway hyperresponsiveness also occurs, and so that's the action of inflammatory mediators causing constriction of the airways. There are also 2 phases to asthma. So the immediate acute phase involves smooth muscle spasm and increased mucus secretion. The late phase is the acute inflammatory reaction, which involves infiltration then of inflammatory cells, the Th2 cells, monocytes, and cytokines. COPD is then the 3rd to 4th leading cause of death globally. So mortality is usually about 50% within 10 years of diagnosis. So it's pretty high. COPD is irreversible, but you can control symptoms and you can control and help prevent acute exacerbations. So COPD is split into chronic bronchitis and emphysema. So chronic bronchitis is your chronic inflammation of the bronchi. It's going to present with your productive cough over a period of months to years. Emphysema, by contrast, is the destruction of the lung parenchyma, and so that's where you get collapse of the small airways, you get gas trapping in the airways, and this is why people will breathe through pursed lips, because breathing through pursed lips helps keep the pressure higher through the airways and helps prevent some of that collapse of airways. It's once again associated with inflammatory response of the lungs to gases and particles in the air. In terms of the medications for these, they will use the same kind of medications but in different orders. So in asthma, you'll begin with your short-acting beta agonist, so something like salbutamol, which is your reliever. And then if you can't control the asthma with that alone, you'll add a corticosteroid, then a long-acting beta agonist, and then other drugs down the line. In COPD, you start with the same, so with the SABA, but then you'll add a LABA before and corticosteroids. The difficulty with the LABA is that you can't give it alone because it will mask symptoms of inflammation. It will hold the airways open, it'll prevent them from spasming, but it won't prevent any of that airway remodeling. And so if you give it alone, it can mask asthma actually getting worse. And so when an acute exacerbation then occurs, it can be more likely to be fatal. You give it, therefore, with a steroid, which prevents that airway remodeling. Okay, moving into the clinical conditions. Sorry about the amount of text on this slide. Hopefully it'll be useful. I've just put in bold some of the kind of key words that you might come across. So for example, COPD, cough that's worst in the morning, smoking history, pursed lip breathing, barrel chest, they're the kind of key things that you're looking for in a presentation that will point you towards COPD. In asthma, you'll be expecting an intermittent cough that's usually worse at night and exacerbated by certain factors such as exercise or smoking. It's accompanied by an expiratory wheeze, and there might be a history or family history of atopic conditions. So that's hay fever, eczema, or asthma, and they're all associated. Here you'll have the low FEV1 over FVC, and it will increase by at least 12% upon administration of a bronchodilator. In terms of pneumonia, it'll be a dry and then a productive cough accompanied by fever, and you're looking for signs on examination such as crackles, increased vocal resonance, and increased vocal phremesis. Tuberculosis is associated with recent travel, weight loss, fever, and night sweats, and you're expecting granulomatous consolidation in the lungs. Tuberculosis tends to prefer the apices of the lungs as well, so it's more likely to occur there. Pulmonary embolism will then likely present with sudden onset chest pain. It's usually pleuritic, so worse on moving, and there'll often be a history of some kind of clotting risk. So something like surgery increases your risk of clotting, a history of DVT, immobilization or a long flight, hormone replacement therapy, all of those can help contribute to make it more likely that someone's got a pulmonary embolism. It's diagnosed with a VQ scan or venous compression ultrasound of the legs, which you might use, for example, if someone's pregnant and can't be given contrast, which is used in the scans. Pleural effusion is associated with stony dullness on percussion and decreased vocal resonance. On an X-ray, you'll expect blunting of the costophrenic angles, which is how you know that there's a little bit of fluid sitting there. Pneumothorax is a sharp, rapid onset of pain. It often occurs in a tall, thin young male, like a basketballer, and it might be secondary to a variety of different causes. There'll be sudden onset shortness of breath as well, possibly tracheal defibrillation and hyperresonance. So the lungs no longer occupying that space, it's just empty air, and so it will be hyperresonant. Interstitial lung disease is associated with occupational exposures, so things like asbestos and coal mining, and it has the triad of cough, clubbing, and crackles. Just a few more key conditions. So we've already spoken a bit about cystic fibrosis. Lung cancer, it could have no symptoms ranging through to hemoptysis, weight loss, chest pain. Smoking history is always key. I'm almost finished. If you guys could just be quiet for another couple of minutes. Thank you. So also with lung cancer, you've got things like Horner's syndrome, which is associated with a Pankos tumour, and so that's where you get your signs around the eyes. So ptosis, meiosis, and anhidrosis, and that's caused by compression of the sympathetic chain to the head. You also might get weakness, so weakness of the T1 nerve root, so that's what you're testing for in the respiratory exam when you test there and check for wasting athena, hypothena eminences. Obstructive sleep apnea, you've probably already done in a PBL, so snoring, excessive daytime sleepiness, and it's associated with high BMI. Pulmonary edema is a cough with frothy sputum. It tends to be worse on lying down and may be associated with also orthopnea. So again, shortness of breath that comes on lying down. I've just got a couple of chest x-rays here. Anyone want to call out what this one might show? There's an arrow there to help. Okay, so that's just blunting of that angle. You can see the angle's really clear here. It's blunted here, so that's your pleural effusion. Moving on to this one. So here you've just got a region of consolidation. It's a region of consolidation. It looks to be roughly confined to one lobe, which is the lobe here on the right, and so that's a lobar pneumonia. This one is a bit more subtle. If you follow the lung fields out to the side, you can see that they stop here, and so that's a pneumothorax. You sometimes get a pneumothorax where it collapses completely in, but this is actually a lot more common, so you've just got partial pneumothorax there, and so it's worth checking. This one has consolidation, looks to be confined to an upper lobe, and so that's more likely to be something like tuberculosis, which prefers those upper lobes. Okay, a couple of questions now. I didn't cover this, but I've just thrown it in because it might come up. Anyone know how to look after a spacer? Yeah, so let's see. You want to wash it in warm water with detergent and let it air dry. You never want to dry a spacer with a tea towel or cloth because that creates friction, which will then affect the medication delivery. Just a couple of conditions here. So if you've got a 24-year-old female, 1 month history of shortness of breath, cough in the evenings, seems to be worse since she had an upper respiratory tract infection, otherwise healthy, suffers hay fever. Yeah. So there are a lot of clues there. That's probably the sort of thing you're likely to get. They tend to give you a fair number of clues. So a 50-year-old male, excessive daytime sleepiness. Yeah. 40-year-old female, just returned from Asia. So that problem. All right. So 40-year-old female just returned from, sorry, I can't do it backwards. All right, that one before, I'm not sure if people were thinking TB. Don't just see Asia and think TB. It can be other things. So in that one, there was the unilateral swollen leg. That's always going to be your DVT. Southeast Asia is also a long flight. So again, DVT risk. And then presentation with pulmonary embolism. In this one, 40-year-old female, cough, swollen nails, crackles. Any ideas? So the swollen nails are going to be clubbing, cough, crackles, and clubbing. So what's that triad? Okay, so that's the triad of interstitial lung disease, cough, crackles, and clubbing. Also take things with a grain of salt. For example, past history, mother dying of AMI, irrelevant. They sometimes throw in extra information, so just make sure you know to sort out, and don't worry if what you've chosen doesn't include absolutely everything. 19-year-old, 1 week history of dry cough, which has now become productive. Vocal resonance and fremitus are increased. Right, so that one's pneumonia. Begins dry, becomes productive. All right, this question's probably a little bit unfair, so I'll just go over it quickly. So you're most likely, again, I can't go backwards. Okay. Your most likely causative organism in a normal community-acquired pneumonia will be strep pneumoniae, so that's gram-positive diplococci. That contrasts to when you go into a hospital setting where a pneumonia is secondary to another infection. So for example, pneumonia that's secondary to influenza. And in that case, you're more likely to have a pathogen like Staph aureus, which is gram-positive in clumps or clusters. So that's C down the bottom. So your likely pathogen can change based on the setting. In most settings for pneumonia, it'll be strep pneumoniae. Following hospitalisation for another infection, it's more likely to be Staph aureus. I'm really sorry to have had to run through that so quickly. If you have any questions, happy to answer them.
No, that's okay.
That was way too quick.
That worked out okay. No, that was